I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Sawh-Martinez. Enjoy.
So this article I'm going to discuss has actually been selected by the journal as the center of a discussion that will happen every month on social media. It's a 3-day discussion, right, Amanda and Raj?
Mm-hmm.
On social media, and this is one of the new initiatives to try to focus in on one of these articles in a unique way with the authors and with interested readers so that we can have some direct interaction with people reading the journal and being able to share ideas and talk about important articles that come across throughout the year. Before I actually talk about the article, I think myself, like a lot of residents, have trouble for the first time learning rhinoplasty and with all the different terms with this procedure and maybe not seeing this procedure a lot until the later years of training. So I just want to point out one article that's a CME from 2011 called Rhinoplasty. I think before reading this article, if you're not familiar with the procedure, haven't seen a lot of rhinoplasties, this article by Drs. Rourke and Ahmed is really a great overview. 25 pages, but really a lot of pictures, a lot of videos of the key maneuvers, algorithms about management of airway and different types of maneuvers during the procedure. I think this is something really good to read, not only for understanding this article, but for the in-service and board preparation as well. So take a look at that CME. This article that I'm going to discuss is an article called Alar Contour Grafts and Rhinoplasty, a safe and reproducible way to refine alar contour aesthetics. And Dr. Rourke's a senior author, and it's by Dr. Unger, Rustation, Small, Pezshek, Lee, and Harris. And they discuss alar rim deformities that can occur in rhinoplasty patients after the procedure that can include retraction, notching, collapse, and asymmetries. And it's thought that certain rhinoplasties will be performed to correct these deformities, but the actual procedure itself can lead to these secondary deformities. And they wanted to specifically evaluate alar contour grafts and whether these particular grafts can be used to remedy these situations. So what they did was look at 50 consecutive patients pre and post-op that had received these alar contour grafts. And they also picked 50 patients as a control that had not received these grafts. And they tried to look at the difference between the pre and post-op in terms of alar retraction, notching, collapse, and asymmetry. They looked at all views of the patients, and they basically assigned a 4-point scale, with 4 being the most severe deformity and 1 being the least severe deformity. These grafts basically are 15 millimeters by 3 millimeters placed bilaterally inferior to the infracartilaginous incisions and now becoming routine use in Dr. Rourke's practice. When they actually looked at the differences between the two groups, aggregate pre- and post-operative score, there wasn't a significant...
Sammy, can I interrupt you for 1 second? When you say in
Yes.
Dr. Rourke's practice routine use, are you saying he uses it in everybody, or what do you mean routine?
Well, I was going to talk about that later, but basically he's saying that in most patients, unless the patient has very strong and well-positioned lower lateral cartilage or excessively thick skin, he uses them quite often. Basically says that there's really no contraindications to using alar contour grafts outside of what I just mentioned. But he does say that they're sometimes not necessary, but routinely he will place them in his rhinoplasty procedures. So a lot of that is basically the main findings that he noted here, and that patients in general with weak lower lateral cartilages or cephalically rotated lower lateral cartilages have a tendency post-operatively to notch or to have alar collapse because of the destruction of the native support. Also scarring and healing on some of the soft tissues can influence the changes of the shape of the ala. So he's using them quite commonly. He didn't say every one, and he says that there's certainly instances where they're not needed, but he's using them routinely. Okay, does that answer your question?
I think so.
Okay. So in terms of what they actually found in the study, it was very interesting. So when he looked at pre- and post-op scores for the non-alar contour graft patients, he noticed that there was a significant worsening post-operatively in terms of retraction, notching, and collapse. When he looked at pre- and post-op scores for where he had used these grafts, he noticed improvement in notching, collapse, and asymmetry. And then if you look at the aggregate scores of all of these factors in the non-graft group, it was 0.32 points worse, and that was statistically significant. Whereas when you look at the graft group, there was an aggregate 0.33 improvement, which was statistically significant. So he's concluding in this study that using these grafts improves the cosmetic results, prevents, and helps alleviate these issues that can occur sometimes after these rhinoplasty patients have healed, and that they are indicated. So, I know that not everybody uses alar contour grafts and non-anatomic grafts, but it would seem in this study that seemed to be fairly substantial with a control group of 50, that it does seem that there is some benefit here. There really aren't any complications or any major side effects associated with this. They didn't notice any graft displacement, migration, extrusion. These, as you know, are small grafts placed into very small pockets. I think that sort of comes down to the point we made earlier that if there's not, that's my question to you, Dr. Thorne, if there's not a lot of downside to using them, and it would appear, at least in this study, based on the ratings of the 3 blinded observers that he had rating the scores, what would be the downside to using these grafts, in your opinion?
No, I agree. I think there's no downside. I think that, though, in my hands, and I thought maybe this is what the article said, it doesn't improve retraction. It doesn't, in other words, it prevents it from getting worse, but the retraction, you're not actually going to lower the alar retraction with that graft. Is that what the article concluded?
Well,
there was one of
they did say that the scores were insignificant for retraction, but improved for everything else. So that is correct.
Right. That's certainly fits my clinical experience. The only thing that I've screwed up about these is making the graft a little too long centrally, medially, so you get a little irregularity in the soft triangle area. So I think it's possible to mess it up, but as a general rule, you don't pay a price for using it.
Right. He does say that once you secure the grafts into their pockets, you redrip the nasal skin, and then if you have any cartilage extruding medially, you simply resect it. But typically, these are very narrow grafts, 3 by 15 millimeters. So this is something as a resident probably took me 10 or so noses to watch to understand how a non-anatomic graft can have such a powerful effect on the overall shape of the nose. And I think this article, as best as you can, objectively looks at it and describes its limitations, but also its power in improving the result in rhinoplasty. And any other thoughts?
Well, just not just the appearance, but the function as well.
Right. In terms of the external valve, right.
One of the key things I think too here is just the historical aspect of these grafts, in the sense that I think people have been using them when there is a problem, when there is notching, or you have a deviation in the rim, and not routinely. I think that's something that's a little bit interesting. Having seen various people in our sort of community here who do them, I would say most, at least attendings that I've seen doing rhinoplasties, have not been using these in their routine primary rhinoplasties unless there's an antecedent issue. certainly in reconstruction, I think we use these a fair amount more. But I think what they're showing here with the support and the improvement in the contour, and the point that even after primary rhinoplasty, you can create these issues that this graft can prevent or minimize. I think that's going to point to this becoming of greater use, right? I mean, it's just one of the many trends in rhinoplasty where we were doing things in that initially open, then closed, and then back to open for the differential and the benefits. I think this will likely become one of the commonplace things that everyone will start using these grafts in their primary rhinoplasties. Is that something that you guys have seen in New York? Well, or in Chicago?
What do you think, Amanda?
No, the surgeon that we work primarily with for rhinoplasty, he does not use these routinely in primary as a preventative measure. He will use them in secondary rhinoplasties where there's an actual issue. But I'd be curious to talk to him and see what he thinks, looking at this article, if it would change his practice.
Yeah, I think I've seen surgeons that do a lot of rhinoplasties use these, I'd say, fairly frequently. And Dr. Borg points out that he really, earlier in his career, he used these only in particular cases. If somebody had collapse or in secondary cases, and then he realized that he really not limited to patients only that had a bulbous or boxy tip, and he again expanded his use of these. So it would be interesting to see in terms of percentage-wise, as you asked earlier, Dr. Thorne, how often, but I'd have to sort of ask him that. But I think that, I would imagine using them more frequently. I just want to point out two articles that are going to be paired and open access for a couple of months that are going to be associated with this article that we just discussed. One is by Dr. Gunter, Rorick, and Friedman, talks about classification of Alar discrepancies in rhinoplasty. And I think it's a very nice discussion of the different relationships between the lateral view, the Alar and columellar anatomy, and talks not only about a classification system, but different treatments that could potentially correct some of these deformities, and I think it pairs very nicely with the article we discussed. And then I think a classic article in the journal, Alar rim deformities by Dr. Guyron, talks about extensively the deformities of Alar rim, what normal looks like, what are the abnormal anatomic variations, and then again, different treatments that can be used to remedy these deformities. So I think for a lot of residents at our level, these are two very nice articles to have a much better understanding of the problems that this particular graft is trying to help. Dr. Thorne, any last thoughts about this article?
No, I think I like it, and I think that article. I think the article that I'm particularly familiar with, Rod and Gunter's article, helped me a lot when I was a resident or early in my career. At least, for those people who don't have a lot of experience with rhinoplasty yet, when you look at the nose from the side, how do you know if the columella is hanging down too far or if the alar rim is retracted too far, or both? So I find that analysis very important, in that article a landmark contribution.
Yeah, just the geometry of that analysis and the lateral view is very, very helpful. And I reviewed it a couple weeks ago, and I thought, I wish I would have known this a long time ago. Doctor,
that's why it's a 6-year program, Sammy.
Yeah, exactly. Dr. Thorne, what percentage of open rhinoplasty cases are you using alar contour grafts?
I don't know. When you come up with a number like this in your head without actually studying your practice, it's apt to be wildly wrong. But I would say over half. And certainly when I watch the patient inspire preoperatively, if there's any weakness, any tendency for collapse of the alar rim, then I definitely do it. And as you say, I don't think I've ever regretted doing it. I've regretted not doing it.
Mm-hmm.
Sort of like spreader grafts.
Right. And what about, do you use lateral curl strut grafts off.
I've never used the. I don't understand. The really smart, like nose doctors, use those. But this Alar rim graft, or what I think I don't know what I always get yelled at by Rod for using the wrong terminology. Like, can I call this an Alar rim graft, or the correct terminology is Alar contour graft?
I think Alar contour is his preferred way, but he does say in the article that don't let the terminology confuse how powerful this graft is. So you can call it whatever you want.
Because it does go at the Alar rim, so that's the term that sort of makes more sense to me. The lateral curl strut graft, you can show me how to do that, Sammy.
Okay, we'll save that for next time.
I actually have a question, Dr. Thorne, real quick too. They mentioned in the article they gloss over what type of cartilage to use for the donor, and they do mention conchal. Would you ever use conchal cartilage for this? I feel like it would be too flimsy, and I think you would want something more solid. Is that true in your experience?
I don't know. I don't think the cartilage has to be very strong. The pieces that you're putting in there are not, huge, and they're not really strong. So I'm not sure. I think if you get a piece of cartilage that fits the defect, I'm not sure it really matters. Any little bit of strength you add to the alar rim. Now, obviously, I guess the worse the collapse, the more you need you're more likely to need septum, which tends to be stronger.
Right. Yeah, I think I've seen them. The preference being on the septal cartilage, just ease of use and not the second donor site. But that's a great question about the strength, Amanda. Yeah,
I've tried to stuff just the portion of the lower lateral cartilage that you resect when you do a cephalic trim, and I've tried to stuff that in there, but it's so flimsy you want to blow your brains out because it's like
get it in the pocket
in a hole. It doesn't go.
One of the other technical points too is just developing that pocket to be just right. I mean, it's sort of a finer, more nuanced dissection, it seems like. Any thoughts or tips on how to do that properly? I know that in this article, I don't think they talk too much about developing that pocket, but something that I think can get people into trouble.
Well, I don't know about trouble, but it clearly it takes a few seconds to do, and if you haven't done it before, it probably takes minutes to do. I put it in from medial to lateral. Now, Nick Tabal, when I've seen him do it, and Sam, you've seen him more recently, I saw him put it from lateral to medial, and he just makes a little pocket, stuff it in. It takes 2 seconds. I can't get the damn thing in that way, but it does make for a tighter pocket, and maybe the graft is less likely to move around if you do it that way. Sammy, how's he doing it lately?
Yeah, I've seen him do it lateral to medial placement, and you're right. He just has a knack. He snips, puts the tip scissors in, makes the perfect pocket, and or Stevens, and just gets it in there. You're right. I mean, I've seen a couple people struggle too because again, these grafts are very, very small, and usually they're basically crafted from leftover pieces, right, of other cartilage you've already put in your columnar strut or spreader graft. So these aren't really your first pick of cartilage pieces anyway. So it can be tough. I think that's something that just takes a little bit of experience and feel on how to make the perfect pocket.
Now, I tend to suture them in mainly because the way I dissect the pocket ends up is big, I think, and they tend to move around, and so I feel like I've got to put a little 5/0 plane suture through them to keep them there so they don't move. But do other people do that, or they just make the pocket correctly and they seem to stay there?
Yeah, a lot of people just make the pocket and leave it. They don't suture it in. So.
But that's a great trick, though. I mean, I've seen the same thing, like Sammy's saying, just make the pocket, put it in. But that is always an issue if your pocket is a little wide, or even if it's not, that graft can still move. But it's actually a great point. We should wonder if you can even ask the authors if they ever suture it in, if the pocket's either over dissected or to create more stability.
Yeah, he doesn't say that he put the suture in this, and I'm trying to think of some of the videos that he's done.
Yeah.
I don't think that he sutures it in.
I think the article by Gyron mentioned suturing it in. I'd have to look back, but I do remember one of the articles that we have does mention suturing it in place.
Mm-hmm.
I was trying to get the video to play at the end of the article, and I was unsuccessful. But does the video show it being placed, and in which direction is it placed in the video?
Well, they use
it from Sorry, go ahead.
Yeah, you were going to say. I mean, they place it in the standard fashion.
What's the standard
from
fashion?
medial to lateral.
I think most people do medial to lateral.
Mm-hmm.
That I've seen. I mean, I've only really seen Dr. Duvall do a lateral placement.
Well, I applaud you guys for coming up with this journal club. It was fun. I learned something.
Well, Dr. Thorne, thank you for giving us your time. And I think Raj and Amanda, I think we're all done. So with that, we'll say thanks everybody for listening. And tune back in February where we'll discuss 3 more great PRS articles.
See you guys.
Awesome. All right.
Thank you, Dr. Thorne.